session with a few comments.
Sure. Thank you so much, Seema, and thank you for being there for this session. The conventional wisdom in patients who present with metastatic disease has been that the treatment would be systemic and local treatment is reserved for individuals with either ulcerating or bleeding tumors. With the advent of very effective chemo, radiotherapy to some extent, but chemo, hormone, and targeted therapy, the response rates have been so great that we are tempted to achieve some local control. And while there is a large body of retrospective evidence, I must warn that a lot of it is hugely biased, but there is randomized evidence, and there are at least 4 trials that have been published, and we have some eminent speakers with us who would give us some insight into it. But primarily, the questions that beg to be answered is it really necessary to undertake loco-regional treatment in patients who present with metastatic advanced disease? That's the first question. And if that's beneficial, is there any subset that might be benefited and the others may not, or benefited more than the others? And lastly, if there is a trial of surgery versus no surgery, in what percentage of only systemic therapy arm there is a need for surgery? These are the 3 clinical questions that trouble us. And finally, are there any biological insights that might just allow us to say whether removal of primary tumor has an impact on distant metastasis? So this would be an excellent human model to understand the impact of removal of primary tumor at the distant sites. We have with us Dr. Seema Khan, we have Dr. Anthony Lucci, we have Dr. Amy Zhu, and as part of panel discussion, Ms. Mason. And I hand over the local responsibilities to Dr. Seema Khan, who is the Professor of Surgery and the PI at the Northwestern Preventive Consortium at the Northwestern University. So over to you, Seema.
Thank you very much, Dr. Budvay. So I am going to kick off with, if I could have my slides, please, with a discussion about primary site local therapy for de novo stage 4 breast cancer. I will be discussing the results of prospective clinical trials. I'd like to thank the program committee for inviting me here. It's a great pleasure to be here. And I have no conflicts of interest to disclose. So just as a reminder, about 6% of new breast cancer diagnoses in the United States are stage 4 at diagnosis. The median survival, 3-year survival of these patients in 2011 was almost 40%. It has improved since then, and we'll be talking about that. In these patients, the intact primary tumor aids diagnosis, as we all know. The biologic subtype influences selection of therapy, but we worry about the fact that it can cause symptoms and affect quality of life. And in 2001, there had been no formal analysis of the value of local therapy for the primary site in stage 4 breast cancer patients. So we looked at the National Cancer Database. The data that were mature at the time were from 1990 to 93. This was 20 years ago. And looked at the median survival by surgical group and found that women who had received surgery for their primary site did show a better survival. And in multivariate analysis, the hazard ratio was around 0.6, particularly if the primary tumor had been completely resected. So this aroused a lot of interest, and many retrospective studies followed. So this is not for you to read. This is just an illustration of a recent meta-analysis showing you how many retrospective analyses have been performed. And there is obviously continuing debate and interest in this topic, because this meta-analysis in 2021 was cited by others 13 times, looking at various aspects of this question. So it's an ongoing debate, clearly. However, quite early in this experience, it was clear that there was either the results that we were observing could be explained on the basis of a consistent benefit across many different populations, or we had to seriously consider the possibility of a consistent bias that was being applied by physicians in different settings, leading to a selection of patients with better prognosis. And these biases have been documented in many of the retrospective studies that have been published. These are the factors that drive departures from standard of care, which for stage 4 cancer, as Dr. Budve said, has traditionally been systemic therapy. So drive departures from that standard of care towards the incorporation of local regional interventions for the intact primary. And the biases that have been reported and observed include better physiology, age and comorbidities, better access to care, better biology of the tumor, including hormone receptors HER2 and grade, and also a lower metastatic burden. And I think Dr. Lucci will be addressing that in particular in the second talk. So unfortunately, these are at best only approximately measured in the retrospective data, and as a result can only be approximately adjusted for in retrospective analyses. And this remains a concern despite the number of studies that have been published demonstrating a survival advantage for women with stage 4 disease if they get local regional treatment. So just as an example, I included this recent study published in 2021 based on the National Cancer Database. And although the authors did try to make for a more homogeneous population and excluded some categories where the data were incomplete, but their evaluation of systemic therapy and the use of surgery and systemic therapy and the use of surgery plus radiotherapy is sort of illustrates some of the problems of this setup. So they looked at surgery before and after systemic therapy, and they looked at the addition of local regional treatment. But of note, and I've clarified this with the authors, the NCDB data at the time that they received did not distinguish between local and distant metastasis, radiation. So the radiotherapy that sort of analyzed in this study actually could have been to the primary site or could have been to metastatic sites. And then surprisingly, they reported that over a third of the patients had oligometastatic disease, which is really not the experience that we expect in a large database that includes a lot of community hospitals. Even in academic centers, that would be an extraordinarily high proportion of women with oligometastatic disease. So their results are shown here. They concluded that trimodality therapy with surgery, radiotherapy, and systemic therapy is best. Again, the radiotherapy could be local or distant. And then the systemic therapy with radiotherapy alone without surgery was worst. And surprising features of this analysis were that oligometastases were quite common. Systemic therapy was used in a small proportion of patients, considering that these were stage 4 patients. And local regional treatment with radiotherapy was indistinguishable between the primary and the distant site. So this just illustrates, despite the fact that it's a very new study published this year, it's not last year yet, that these analyses are really fraught with hazards in terms of reaching definitive conclusions. So we need to turn to prospective trials, because there have been some now. And these are listed here. So there are randomized trials, and then there are some non-randomized trials. So of the 5 randomized trials that have enrolled patients, The Japanese study, JCOG 1017, is going to be analyzed hopefully next year in 2022, so we can't talk about that. But we will discuss the others, and then the non-randomized trials are listed there. So for the randomized trials, there were two essential designs that were used. The first was where the patients who were registered received systemic therapy initially that was either defined by the protocol or appropriate to their tumor and other characteristics. And then following the systemic therapy, they were registered. If they did not progress on systemic therapy, they were randomized to either continued systemic therapy or to local regional treatment for the primary site to be followed by continued systemic therapy. The alternative design was where patients were registered at the outset and randomized immediately to either systemic therapy alone or to local regional treatment followed by systemic therapy. So for the first design, 3 trials have, as I said, accrued patients. The Japanese trial is not complete. The Indian trial led by Dr. Budve has been published a while ago now, and the the North American trial, E2108, is currently in press, so hopefully you'll see the full manuscript very soon. The surgery first or randomization first, upfront randomization trials were MF0701 by the Turkish Federation, led by Dr. Saran, and the positive trial in Austria, led by Dr. Fitzel. The Turkish trial did reach full accrual and has been published. The Austrian trial has also been published but did not reach full accrual. They enrolled 90 patients. So to compare the 2 trials with upfront systemic therapy then, the inclusion, the systemic therapy plan was a little bit different between Tata Memorial and 2108. So it was mostly anthracycline-based chemotherapy that was used up front. In the patients in Mumbai in 2108, it was optimal systemic therapy as defined by the physician according to national guidelines based on tumor and patient characteristics. In terms of so they're very similar trials. I'm just highlighting the differences. So in terms of the exclusions, in Mumbai, women with more than 3 or more organ sites of metastatic disease were excluded, as well as those with extensive liver metastases. And also, if there was a single metastatic lesion that was amenable to local therapy, those patients were excluded as well. In the North American study, we only excluded women whose survival was expected to be less than 6 months. And those with a single metastatic lesion were allowed to participate as long as that single site was biopsied and proven to be metastatic. So without going into the details of this flow, I just want to point out that the local therapy, the numbers were relatively similar, and we'll go into the numbers again, but the local therapy design was also similar, except that in Mumbai, the axillary dissection was mandated as part of the local regional treatment, whereas in the North American study, sentinel node biopsy was allowed. And these are the survival results. So you can see that the 2 arms, the survival curves are entirely overlapping. If they weren't in different colors, they wouldn't be distinguishable, suggesting absolutely no benefit in terms of overall survival for the use of local regional treatment for the primary tumor when it follows an initial period of systemic therapy. And the only other thing to note about this, and I actually don't know where the pointer is. Here, there it goes. So the only other thing to note about this is that along the y-axis, you see that the time frame here is up to 3 years, and in the North American study is up to 5 years. And the survival is different. So here at 3 years, the overall survival is just over 20%, and in the North American study, it was around 70%. So somewhat different survival experience, but otherwise very similar results. And looking at the upfront randomization trials, the one on the left is the Turkish Federation, published by Saran et al., and on the right, the positive trial. Very similar design. The local regional treatment also did not have any substantial differences. On the left here, you see the results from the Turkish Federation. So their primary endpoint was 3-year survival. And at 3 years, the survival was not significantly different, although it was trending towards favoring the surgical group. At 5 years, there was a significant difference, with 24% surviving 5 years in the systemic therapy group, and about 40% surviving in the local regional treatment group. In the Austrian trial, much smaller numbers, of course, but okay, there is the. So this systemic therapy arm is doing a little bit better than the local therapy arm, but the difference is not significant. So this hazard ratio of 0.6, the point estimates favors the systemic therapy arm, but overall no significant difference. So different results in these two trials. When we look more closely at the discrepant results between MF0701 and 2108, we see that the number randomized was very similar. The average age was not too different, but there were some differences in the randomized groups. So in the 0701 study, hormone receptor positive tumors were more frequent in the surgical group. Triple negative tumors were more frequent in the systemic therapy group, and bone-only metastases were more frequent in the surgical group. So the two favorable features here, hormone receptor positive disease and bone-only disease, was more frequent in the surgical group, and the triple negative were less frequent. When we then go to the survival results of these studies, we can see that the 3-year survival is 60 versus 51% in 0701 at 3 years, and 70% in both arms in the 2108, the North America trial. And the 5-year survival for the Turkish Federation trial is 40% in the local regional treatment arm, 24% in the systemic therapy arm, whereas in 2108, it's 40% in both arms. So it seems that the difference in these two trials is really a poorer outcome in the systemic therapy arm in 0701, and not really, not a significant difference between the between the local regional treatment arms. So the local regional treatment arms achieved 40% survival in both studies, but the systemic therapy arm reached a 40% survival also in the US-Canadian study, whereas in the Turkish study, the survival was much worse. So that significant difference, just to remind you of the survival curves, is shown here. Again, making the point that the difference really in these trials is in the outcome of the systemic therapy arm in the Turkish trial. So subset analyses are obviously of interest. They've been performed in most of the trials that have been reported so far. This is the subset analysis from Dr. Budbay's trial. So pre-planned subset analyses, really no group that benefits more clearly than any other group. Whereas in 0701, where subset analyses were not pre-planned but were performed post hoc, there were differences seen in the hormone receptor positive group, significantly better outcome in the ERPR positive, also among women who were younger, and also among women who had bone-only disease, particularly if it was a solitary bone metastasis, where the upper bound of the confidence interval was 0.98. So this is the basis for the subsequent prospective study from the Turkish Federation. We looked at subset analyses in 2108 and the two subgroups that have targets for therapy, hormone receptor and HER2. The results were exactly the same as the main study, no difference in survival. Whereas in the triple negative breast cancers, there was a difference that was significant favoring the systemic therapy group, but it's a very small number of patients, only 20 that were randomized, so this is clearly a tentative finding, but nevertheless significant. And then just at the bottom of the slide, you can see that we did in retrospect classify women as having oligometastases or not. This was not a pre-planned analysis, but there were 47 women with oligometastases, 41 were randomized, and there was no difference by treatment arm among women with oligometastases. So going on to local control, all 4 trials reported results on local control and showed consistent results, actually. So there was improved local control in all 4 studies. You can see the curves for the Mumbai and North America study. For the others, you can see the estimates that were reported and all going in the same direction, protection from local regional recurrence. But does that translate into quality of life, which we thought was an important question? And these are the 2 studies that actually prospectively measured quality of life and reported it. And we see no improvement in quality of life in either of the trials. And there was attention paid to the primary site, so local regional symptoms in terms of the breast and the arm and the shoulder. Those were queried for prospectively, and we see no advantage with local regional treatment. The only significant difference here is at the 18-month time point that we actually designated as the primary endpoint for the quality of life analysis, and that is going in the wrong direction, at least per the hypothesis. So it's the systemic therapy arm that experienced a better quality of life at 18 months from randomization. So we talked about the randomized trials and the somewhat conflicting results so far. There are also, as I mentioned, non-randomized studies, one in the US and one in Turkey. So TBCRC was led by Terry King, and the 1401 was led again by Dr. Saran. And the TBCRC was really intended also to collect samples from women with stage 4 breast cancer, and also to look at prospectively at their treatment experience and their survival and outcome experience. So it was a relatively small study, 112 women were enrolled. Of these, 94 responded to treatment and the remainder did not. And so they looked at outcomes based on response to treatment. And you can see that the black line, which is women who did not respond, did poorly. The red and green lines are women who did respond and either received or didn't receive surgery, and there was no difference in the outcome there. So these results suggest that the outcome for women with stage 4 breast cancer is determined to a much greater extent by their response to systemic therapy than by the use of surgical treatment. So these are the survival numbers. Poor survival in women who were non-responders, much better in responders, but not different between the surgical and the non-surgical groups. So this is the 1401 study, and I know that Dr. Lucci will be addressing this as well, so I'll just go through this quickly. This was a group of patients who had bone-only metastases. I'll just point out that 6% of these patients had their diagnosis confirmed by biopsy. The remainder were diagnosed by PET-CT and bone scan, and they received physician's choice systemic therapy. There was actually, as in the retrospective studies, a very marked difference in the groups that experienced the 2 treatments, systemic therapy alone or systemic therapy with local regional treatment. And you can see all the significant p-values here and the difference between the groups. The things that did not differ in this study were the hormone receptor status and histology, and the follow-up interval between the two groups. Dr. Lucci will talk about this, so I'll skip that. But I just want to show you that the subsets that were analyzed all show favorable trends for survival. The only exception is triple-negative breast cancer, and here you see that the hazard ratio is still 0.5, but it crosses the interval bound, the bound of unity, so it's not significant. So this is a positive study. In my view, is more hypothesis generating than providing definitive data, and it'll be interesting to see where these data go from here. So the number of bony lesions did not seem to affect the magnitude of the benefit. It was all similar across. So then when we compare these results to results from the randomized trials where there were subset analyses looking at bone-only disease, we see that there were 100 women with bone-only disease in 2108, 102 in, 100 at Tata, 102 at 2108, 126 in 0701, and 34 in positive. And this amounts to total of 362 women with bone-only disease who were entered into these 4 trials. And in all of these trials, there was no significant survival advantage for bone-only disease. So again, it's a question that is probably pertinent at this point, but I don't think has been answered. At least there's no data so far suggesting that there is improved survival in the randomized trials. The prospective registry is a different issue. So putting it all together then, I would say that the retrospective data continue to show an association with improved survival benefit and continue to be published when looking at patients with de novo metastatic breast cancer who receive local regional treatment. But of the 3 clinical trials that have reached full accrual, 2 show null results. And I should put in a sort of caveat here. So I'm saying that they reached full accrual, but we actually in 2108 had to decrease our accrual goal because of low accrual. So that's an important parenthetical notation, I think. Nevertheless, 2 of the 3 completed clinical trials showed null results. MF0701 we've discussed, it did show an advantage for patients undergoing local regional treatment, but because of the, looking at the survival experience in more detail, I think it's reasonable to ask whether this really reflects just poorer survival in the systemic therapy arm related to adverse biology in that arm, or whether it's really better survival in the local regional treatment arm. And then the other point that Dr. Xu is going to address, but I'll just mention as an introduction now, is that there is a lot of interest in local regional treatment for metastatic lesions. So in those trials that are addressing local regional treatment for metastases, many of them are either requiring or recommending that the primary site be controlled if the primary tumor was intact at diagnosis. So we will not be able to answer the question about local regional treatment for the primary site and oligometastatic disease from those trials because there's no randomized comparison, obviously, and the trials mostly require control of local regional disease. So it'll be interesting to hear Dr. Xu's comments on that. So I think that the value of local regional treatment for the primary site in the oligometastatic setting will not be addressed by those trials and will need independent consideration. So in conclusion, again, available level 1 data provide little justification at present for a physician-recommended treatment of the primary site for local regional treatment as a means of extending survival. Although local control is improved by the use of primary site local regional treatment, so far this has not translated into improved quality of life. And that's actually very sobering because, you know, especially us surgeons, we tend to think that the effects of local regional treatment go away over a relatively short period of time, maybe 6 months to a year. And at the end of that, women will really be feeling better about the fact that their tumor is controlled locally, but these data don't support that idea. And then primary site local regional treatment, I think, can be considered if the primary tumor is progressing, but the distant disease is well controlled with systemic treatment. And that sort of relates to the oligoprogression treatment that Dr. Xu, again, is going to address in greater depth. And then just as a reminder, JCOG 1017 results are expected next year, and I think we're all anticipating them eagerly. And then finally, oligometastatic or bone-only disease may present a distinct subset where local regional control influences survival, but this remains to be proven. So with that, I thank you for your attention.